I'm David Harper. I'm a senior fellow at Chatham House, and I've been closely involved with my friends and colleagues from HITAP and from USAID in planning and organising this webinar. I'm so pleased you're able to join us today. Welcome to all of you on behalf of the Prince Mayadar Award Conference. Now, I've been very fortunate over the years to have been involved with PMAC, and we've covered many of the areas of interest to the global health community and others, from infectious diseases and epidemics, the spread of emerging infections through non-communicable diseases, for example, all the way up to and including universal health coverage. But today we're in the middle of an unprecedented crisis. And so the discussion that we've got to look forward to is even more important and timely. We've been hearing over the past few weeks about the amazing developments in vaccine, the progress that we've made towards having a vaccine ready to go through the regulatory system so that it can be used in the mass vaccination programs that are going to be very important in helping us tackle and fight this virus. But even mentioning the regulatory systems and the challenges that still are to be faced, it's very important that we see these science and technological advances in the context of the whole of society itself, and particularly in terms of the policy making and the decision makers' consideration of all of the science and the technology. Important as vaccines are, it's just an illustration of the critical dependency that we have on science and technology, not only for the fight against this virus and COVID-19, but for many, many other challenges as well. Today, I'm delighted that we have with us some of the world's leading experts to provide us with their views and insights and to help answer some of our questions. But enough from me, let's get on to the interesting part of the discussion. I'm pleased to hand over now to our moderator for the webinar, Cecilia O. Cecilia is the program advisor at the UNDP. She's based at the UNDP Bangkok Regional Hub in Thailand, and since 2014 she's coordinated the Access and Delivery Partnership, a global project led by UNDP in collaboration with TDR, WHO and PATH, aimed at supporting low and middle income countries to reinforce their health systems through strengthened institutions and human capacities. Over to you with thanks, Cecilia.
Thank you very much, David. And it's a pleasure to be here. I wanted to welcome everyone again. It's evening here in Bangkok, but I'm sure it's a good morning and a good afternoon, as well as an evening to all of you joining us from various parts of the globe. I'm very pleased to be moderating this session. I believe it's going to be a fascinating session entitled Accelerating Advances in Science and Technologies to Prevent, Detect, Respond to, and Recover from Future Threats. Now, as the moderator of this session, I think I have maybe three key responsibilities. The first one is to introduce or maybe set the context for the discussion that we will have before us. As David has said, we have an exciting list of speakers who are global experts in the field that they are in. So I will be happy to introduce them as they come on. The next job that I have is to explain and describe a little bit about the session format. And then finally, I think it's really to remind you of the housekeeping rules. So let me just start by saying that I think, as David pointed out, as we're sitting right now in the midst of a pandemic, we are trying to look at the options to address and to respond to this pandemic. But I think it's also unavoidable that we now start to think about how we can expand our knowledge base in terms of being prepared for the future threats that we might face. And technology, science and technology, as we've said, technology has been identified as a mega trend that's played such a central role in our responses to this pandemic, as well as our responses to other public health issues. But it's also obvious that we must invest not just in advancing science and technology, but also in terms of investing in the processes and systems that link the advances in science and technology to policy making. And so this webinar, I think, is one that is forward-looking. We want to be looking at how we can gather the lessons, the early lessons that we are now seeing in terms of how we address and respond to this pandemic, the sorts of structures and systems that we should put in place so that we can learn how we are able to translate advances that we make in science and technology into effective policy decisions, and including policy decisions that are politically acceptable to the population. So here, I think we have a list of 4 speakers who will speak to these issues, and I think we, will learn very much from, what they have to say. Now, just before we go to them, I think it's also my job to then tell you a little bit about how the session will go. We will have a keynote speech by Dr. Sylvie Briand, and then we will have interventions from 3 other speakers, Dr. Tegan Blaine, Dr. Nantasit Luang Asanatip, and also Dr. Naveen Rao, who will each speak for 5 minutes. After that, we will go into a moderated question and answer discussion or Q&A. And in terms of the housekeeping rules, I know that most of us are no longer strangers to the Zoom processes and the Zoom functions, but just to remind you that there is at the bottom of the screen, a Q&A box, and we would invite you all to type in your questions as you have them. As the speakers are speaking, if anything comes to you in terms of a question that you'd like to put forward to the panelists, all the speakers, or to one individual speaker, please do so, and then we'll try to get to them during the Q&A session. And I think that really is, all that we need to mention in terms of housekeeping. For the speakers, we are trying to keep to the time that we have. It's a short session, so you will get a reminder for the keynote speech. You will get a reminder 5 minutes before the end, and for the others, you'll get a reminder 1 minute to the end. And I think that's probably all that I need to say for now. And I will start to introduce our first speaker. I'm very pleased to welcome Dr. Sylvie Briand. She's the director of the Global Infectious Hazards Preparedness Department at the World Health Organization. And Dr. Briand, I believe is an expert in terms of infectious diseases. She has been at the WHO and working at the Department of Global Infectious Hazard Preparedness, or the GIH, which advances global efforts to prevent and control existing and emerging infectious diseases. At the moment, Dr. Briand is actually the technical lead for the COVID-19 response. So no better person than Dr. Briand to lead us in this keynote presentation. So over to you, Sylvie.
Thanks a lot, and good evening, good morning, good afternoon, everyone. It's really my pleasure to be with you today, and I will share my screen so that I can show you a very short presentation to introduce the subject. So I hope it works for you as well. And so I will just briefly go over the new technologies that have been in use during this pandemic and to show you what could be the future with such technologies. So I will use as an overview the diagram we have developed for this booklet called Managing Epidemics. We published it 2 years ago. It was a great success actually because we reviewed all the major epidemic diseases we have now, and to help people how to manage epidemic, we have developed this 4 square matrix. And these are the key activities you need to do when you are dealing with an epidemic. It's coordinating responders, having health information, communicating risk, and developing health intervention, of course, to manage the epidemic of diseases. So I will use this 4 square scheme to drive you through all the new technologies that have marked this pandemic of COVID-19. So first, let's start with the coordination. As you see, we are all connected through this platform, and there are many more platforms existing actually. But what it means is that coordination nowadays is slightly different. Before, we used to have meetings, face-to-face meetings. Now we have a lot of video conferences, and it changes a lot the way we work together. But nevertheless, it allows us to a good coordination. So I don't know exactly what will be the future of those platforms. I suppose that soon we might even be able to have more visuals or have different properties that allow us to feel even more closer one to each other. But for the time being, definitively those communications platform have changed the way we coordinate the work on those major events. Then on health information, so what we call health information when we talk about epidemics is all the data on health, so the cases, the deaths, but also the R naught, the epi curve and so on, but also the health indicators. I mean, the number of occupied beds, the number of masks and so on. Also the response indicators, the number of responders, the distribution of cars, and all the items that you need for the response. But also some specific analytics like the nowcasting or the forecasting, trying to anticipate what will be the evolution of the outbreak and how you can better respond to it. So all this information is one we collect during an epidemic, but nowadays, I mean, with this new technology, the collection has changed because we have the capacity to really detect things earlier on by extracting the information from the media, for instance, and we have since 20 years now a system at WHO that allow us to screen every day the media data and take out of it some signals. And so as an average, we have 3,000 signals per month. We consider 300 among them, and usually we investigate 30 signal or 30 outbreaks per month to monitor the outbreaks around the world. And so we really use a platform and big data, let's say, to do this. Similarly, we do have now new platforms that allow us to combine different types of data. For instance, the data I mentioned earlier, we have dashboards that capture the number of cases and deaths, but also the number of beds and the percentage of occupation of those beds in ICU, for instance. But now we also have platforms that can take into account social data, economic data, mobility data, so a much more complex system that allow us to understand this multifactorial event that is an outbreak. We have also the possibility to link different type of databases like the lab and the epidemiology, which seems fairly obvious, but unfortunately in the past it has been very challenging actually to link different databases. But now with the new technology, it's becoming easier, and it's very helpful to monitor an outbreak disease. And then we also have new types of data that are coming in the management of outbreak, like for instance, the gene sequencing. And now we have real-time sequencing. And so we can also monitor viruses. And through this capacity of analyzing their genome, we can also see if it's which kind of strains are circulating and if those viruses are linked and what is the kind of epi-link they have between them. So all of those technology really give us a new perspective on data ownership, because actually we can dig the data from different database or open sources. So we don't need anymore to be the owner of the data. We just are the user of the data. But also it raised some issues regarding the privacy, the confidentiality. And as you have seen with, for instance, new apps for contact tracing, there are a lot of questions that are being asked to the apps developer about how can we still protect individual and their freedom. So all of these questions are really a very important philosophical question that we will have also to discuss when we talk about new technologies. And finally, what is clear is that we do have a lot of data and we can access a lot of data, but what is becoming more and more important is really the analysis of those data and also the insights, so that we can really bridge between data, crude data, and the policy decision that comes from those data sources. So another point is the communication, and we have seen during this COVID-19 pandemic a tsunami of information, some accurate, some not, that spreads alongside the disease outbreak, which we call it infodemic. And this infodemic has been amplified by social media and the possibility that we can spread information very fast and everywhere. So based on this, it has revolutionized slightly our way of doing risk communication and community engagement, because now we know that we need to do this not only offline, but also online. And we have developed tools to monitor this conversation online and try to listen and understand the concerns of the public on both worlds, the physical world, but also the virtual world. And so, but to support this kind of a new approach to risk communication and community engagement, we have also developed a scientific approach. It's called the infodemiology. And we need also a new workforce. I mean, people with different skills than the ones we had before for risk communication and community engagement. And we have launched the first training cohorts of infodemic managers. And finally, health intervention. There have been a lot of revolution in this. And I already mentioned the apps for contact tracing that support this public health activity. But one of the revolution due to new technology is really the development of new vaccines. And you have seen very recently the announcement of a vaccine based on the new technique on messenger RNA. And this is a completely new technology that has allowed us to develop a vaccine in a matter of few months, while before we would have needed probably years to develop such vaccines. So I think there are also a lot of innovation in this aspect, in this part of the health intervention. And finally, I think this is my conclusion. Everybody wonder what's next, because it goes so fast and we have so many new technologies. So I think this will continue to evolve and we will have more and more new technologies. But I think at the end of the day, what really matters is that we need to integrate the human factor in it. And at the end of the day, those technologies are here to serve humans. And so we need always to remember that humans needs to be at the center, and they need to be using those technology and not being manipulated by those technology. Thank you very much.
Thank you very much, Sylvie. That was great and right on time. I think this sets a very good framing for our discussion in this webinar. So thank you again, and I'm sure there will be questions for you. But it now gives me pleasure to go to the next speaker, who is Dr. Nantasid Luangasana. Dr. Nantasid is a postdoctoral research fellow. He's a health economist and a mathematical modeler at the Mahidol Oxford Tropical Medicine Research Unit, or MORU, in Bangkok. And Dr. Nantasid is going to be talking to us about, I guess, a very current topic, which is the use of, or the role of early HTA, or health technology assessment, in determining value for money of vaccines. So Dr. Nantasid, over to you, 5 minutes. Thank you very much.
Thanks, Cecilia, for the introduction. So could you please share my screen, please? So yeah, I want to thank PMAC and HITAP who invited me to share some of the thought on the early HTA of the COVID vaccine. The HTA, or the Health Technology Assessment, is a systematic evaluation of the properties, effects, and the impact of the health technology, which covering direct and indirect consequences of the intervention. The elements that need to be accessed is whether it's like having impact to the people or the population in terms of safety and efficacy or effectiveness, and would it have the issue on the equality if we implement it to some of the population and not to the others. Access, whether in practical, whether it's feasible to implement it, and is there any resources to be invest more in terms of training or people who have skill on those to deliver those intervention. Is there any ethical issue to on that intervention? And lastly, about the finance, whether it has value for money and the budget that we need to pay on those new intervention. And this information will aim to inform decision maker whether they should adopt the new technology to the population or in the national level or other level. This kind of framework usually work with the intervention that available just now, and this could be applied to the intervention or the pharmaceutical product that are developing or in the research and development process to guide or to identify what is the good characteristic or what's the property that help to maximize the benefit or having maximized the value to the population. And this is the case for COVID-19 vaccine, where we are like looking for, and we have just good news from the news recently. So there are several essential elements to evaluate for the early HTA of the vaccine. First of all, knowing about the clinical information of the COVID infection would be helpful to design the vaccine. Who has the most incidence in terms of age or sex, how severity, the percentage who has worse condition, and hospitalization rate and case fatality, and also how long that patients could be infectious to others. That would be helpful to estimate the burden, the baseline burden of the COVID. One of the essential thing is about the natural immunity that people could have if they have infection. In terms of comparing with the vaccine, those duration would have meaningful information when we develop the vaccine. And of course, for the vaccine itself, for the vaccine characteristic, efficacy of the vaccine would not have only one efficacy. I think the common efficacy that people know is to reduce susceptibility or prevent people to be infected, but not only for that. There are sometimes the efficacy of the vaccine could not prevent from the infection, but just stop that patients or that people to transmit to others. That another characteristic of the vaccine as well. They just reduce the severity. Instead of having the severe, they have just small cases or just no symptoms. Another characteristic of the vaccine is the vaccine duration. I think the most preferable is to have long lasting. I mean, the more duration is the more preferable compared to the natural immune. And we want to have less adverse event. And we want to have like good logistic condition, keeping it room temperature and cook it for like many years. And it could be easy to deliver if they have good condition for that. Then for the vaccination strategy, I think at the current period, the vaccine would be in the global demand, and the country would have limited number of doses, and given limited doses, how would the vaccine distribute to get the most impact to the population? That will be the issue, how to distribute this, to design the strategy to distribute the vaccine. That could be the target population to set priority for vaccination. That could be the high risk group. Let's say, for example, to focus on the healthcare worker who has more contact to the patients, or the high incidence group, or the high mortality, or could be distributed as an age group in elderly or in adult who has more relatively has higher mortality. Then the last,
just to wrap it up, please. Thank you.
Okay, and the last issue is about the baseline situation or competitive intervention, where we have the non-pharmaceutical intervention like hand hygiene, masking, social distancing, and travel restriction, or track test, trace, and isolation. That would be a competitive intervention to vaccine. And the level of pre-immunity, we like to know what's the percentage of the people who already have immune. That would be determine how much we want the vaccine. So yeah, to wrap up, I think these are the usual crucial information for evaluating the vaccine to see the value for money. Thank you.
Thank you so much, Dr. Nantasit. I think that was a really interesting discussion on the early HD and its uses to what is a very topical discussion now. And I'm sure there will be questions for you on this. But let me turn to our third speaker, who is Dr. Tegan Blaine. Dr. Blaine will be talking about understanding the intersection of climate and health to better prepare for pandemics. Just a quick introduction to Dr. Tegan Blaine. She is the founder and principal of the Blue Can Group, which specializes in consulting around climate change leadership and action. With over 20 years of experience in the climate science and policy and international development, I think Dr. Blaine will be able to take us through the issues of climate change and the links to pandemics. So I turn the floor over to you, and you have 5 minutes, Dr. Blaine. Thank you.
Thank you so much for the introduction, Dr. Cecilia. Good morning, good afternoon, good evening. It's wonderful to be with you today. I come from a different background, specifically around climate change impacts on health, but I hope that a couple of the lessons I share are adaptable to a variety of different health situations, and especially dealing with pandemics. I wanted to talk about a couple of examples, one from my experience at USAID and one that is derived from published research about how models connecting weather and climate data can be useful in the prediction of disease. This one is from Mozambique, which is a very different country than some of the countries have been indirectly discussed before, because it has such low capacity, both for some of the records around health incidence of a disease, but also in terms of its records around weather and climate trends. However, some work that we did with the government there allowed us to actually predict both diarrheal and disease and malaria days ahead of time by connecting weather information to health information, we were actually able to look at how small temperature variations resulted in changes in diarrheal patterns several days later. And that was also true of warmer days and warmer nights for malaria, as well as changes in rainfall. These kinds of predictive models, both on very short timescales and on seasonal timescales, are becoming a reality. This is another example from the island of Réunion, specifically around dengue. It is now possible to predict dengue outbreaks quite a bit in advance. This is from a paper that actually looked at several different health variables and outcomes, past outcomes to test the models. And it is very clear that several climate variables or weather variables are closely linked to disease outcomes. But now I'm going to turn off the slides and just want to talk a little bit about some of the challenges inherent in doing this work. There are three things that I'd like to talk about. Firstly, although it's great to have some predictive models, there are some very real challenges in making predictive models work. One of the biggest ones is in getting the health community to communicate with other communities that are not necessarily traditional partners, like the weather and climate community. Many departments of health or ministries of health are not set up to work with hydromet services from which they need to obtain information to develop these kinds of models. And so establishing new relationships, establishing ways to work together, better understanding the data strengths and the data weaknesses of different fields, and really developing not just the human relationships, but the scientific relationships don't necessarily come naturally and have to be something that are consciously built. Secondly, there are real issues in integrating the output of models into strategic planning and response processes. I'll tell you a short story from our experience in East Africa. We had worked to invest in a new model around malaria predictions that gave one particular country an idea of what the malaria patterns would look like several months in advance. Our partners went to the government and said, we have this great information. These couple of regions in your country are going to experience very bad malaria outbreaks this year. But the government response was the following: we only send out medical supplies and drugs to those regions 3 times a year. Our shipment just left. We are not going to be resupplying that region in the short term before the timeline of your predictions. And so that's an example of how a model was developed without really thinking about what the local timeline was for actually being able to respond to that information in substantive ways. And so thinking how models interact with the really human processes of planning, of organizing, of actually responding, and what that means for when model information needs to be conveyed to decision makers and how decision makers will actually use that information is really critical. And then the last lesson is not from the developing context, but is more from our experience in the United States. We also need to get people to trust models. And that is a very human issue. Sylvie mentioned the human component of all of this. And I think it is a critical thing that we need to think about. What we're seeing in the United States is sometimes government professionals and definitely people on the ground are distrusting the models about how to reduce COVID incidents. And we are not necessarily changing behavior in the United States. And so thinking about the human dimensions of this is absolutely as critical as all of the scientific dimensions. I'll leave it at that. Thank you so much.
Wonderful, Tegan. I think that's, again, the message about how we sort of ensure the human interactions with the technologies and the modeling, a message that I'm sure we'll revisit again. Thank you very much. I'm going to quickly turn into our final speaker, who is Dr. Naveen Rao. Dr. Naveen Rao will speak to us on the issue of the role of technology in informing decisions and delivery of health programs. Now, Dr. Naveen Rao is Senior Vice President of the Health Initiative at the Rockefeller Foundation, where he leads a team focused on advancing precision public health, empowering community health workers with insights from data and analytical tools to accelerate progress on health outcomes. So I think no better person to round us up in this session. Please, Dr. Naveen, over to you.
Thank you, Cecilia, for the introduction, and thank you to the organizations of the Prince Mahidol Award Conference for inviting me to participate. It always helps to be the last because I can build on all the comments that were made and some really interesting and insightful comments. So I enjoyed listening to them too. My name is Naveen Rao, and I'm the Senior Vice President for Health at Rockefeller Foundation. And I'm excited to be part of this timely conversation on accelerating advances in science and technology to prevent and respond to future threats, as this is the key priority for the foundation. Too often, our health is determined by a birth lottery, meaning that who you are and where you are born determines how healthy you will be. Factors like income, education, and the quality of the air you breathe have a long history of indicating whether and the extent to which you will stay healthy or ill. And it shouldn't be that way. It shouldn't be just a lottery. While prevailing wisdom used to be that money or lack thereof was the primary driver of inequity, the class divide was money, those who had and those who didn't have. And those who had money had better health than those who didn't have money. I predict that this class divide of the future will be access to data. And once again, those who have access to data will have better health than those who don't have access to data. And it shouldn't be that way. But this uneven distribution of data is exacerbating existing health disparities, especially for the world's poorest and most vulnerable. Collecting better data and leveraging technology to inform our decision-making and resource allocation is essential to closing the gap on these disparities and to take targeted action to ensure the right people get the right care at the right time. The COVID-19 pandemic is a strong example of how harnessing the power of data and tech can make an impact. For example, we can track the virus within specific areas using COVID-19 test results, allowing us to send resources to affected communities while protecting others from further spread. We know this works because we've seen this strategy in action. Take, for example, South Korea, who placed a strong emphasis on expanding testing and tracing contacts early on in the pandemic. Using resulting data, officials were able to encourage self-isolation and break the chains of transmission before further spread could occur. As a result, South Korea's COVID-19 response ranks amongst the fastest and most effective. Its experience with the virus demonstrates that accurate and timely data is essential to achieve health goals and save lives. This is the idea behind the Foundation's Precision Public Health Initiative, which aims to drive progress on the world's greatest public health challenges using digital tools. While data has already transformed many aspects of our lives, we have yet to see this translate into impactful health interventions that are available and are accessible to those who need them the most. Let me give you a simple example. Using data, Netflix can tell me which movie I am going to watch, even before I know which movie I'm going to watch. That is the power of predictive analytic tools. It exists in certain private sector. Why can we not bring it to public health? We lack these tools to target preventive interventions in vulnerable communities. For example, high-risk pregnancies. It shouldn't be like that. Our goal at the Foundation is to change this by harnessing the full power of data to improve health of the populations on a global scale. Digital tools like big data, artificial intelligence, cloud computing, and predictive algorithms can help us identify communities at risk for certain health issues. This, in turn, allows us to direct resources to where they are needed the most. That being said, as we turn to data and other digital tools to bring healthcare into the 21st century, we must also consider user privacy and data security. Both are crucial to protecting the individual and ensuring the information is used in an appropriate manner. Our goal is to ensure technology works for the people who need them the most, not against them. Investments in data will continue to be essential even after the COVID-19 to ensure universal access to healthcare. That's why 3 weeks ago, the Rockefeller Foundation announced a $1 billion commitment over the next 3 years to catalyze a more inclusive, sustainable recovery from the pandemic and improve health outcomes for all. As we go forward from COVID-19, the Rockefeller Foundation will focus on addressing inequities made worse by this virus and protect and improve the lives of the world's poorest people. To achieve this, we will invest in scaling up equitable access to COVID-19 test and treatment and the vaccines around the world. In addition to supporting initiatives to strengthen health systems, ensuring that the right mechanisms are in place to better care for people long term. In conclusion, there is no going back to before COVID, but with data and analytics, we can create a stronger, more resilient health system that are able to anticipate potential crises before they erupt and deliver care where it's needed the most. While the pandemic has stopped the world in its tracks, it has also created opportunities to modernize healthcare and use data to save lives. By working together, I know that we can rise to this challenge. Thank you all for tuning in, and thank you to the PMAC. Rockefeller Foundation and PMAC have a long, strong history of working together, going back 80 years. And thank you, PMAC, for bringing us together to forge a path for a better health for the future for all of us. Kop kun krab.
Thank you so much, Dr. Naveen. I think that was a great, sort of presentation to round up, our fascinating discussion. I want to go into the Q&A session now because there are a couple of questions for our panelists. But I think there have been a number of keywords that have come into in all of the presentations and discussion, which is really, looking at technologies, how we use data, how we use modeling, and then making sure that there is the human interaction part of it, and how do we translate that into health outcomes for all of us, and issues including access and, sort of ethics come into play. So now I would like, and all our panelists are all on video now, thank you very much, without me asking them. This is great. We have, I guess, a short 15 minutes for a discussion, but I'd like to start maybe with Sylvie with the first question, and I will ask the PMAC Secretariat to help me put question 1 up, which is essentially to look at the issue of how the different new applications and software will guarantee data sharing amongst healthcare organizations and institutions at both the country and global levels. I think that they are going to try to put up this question on a slide so that we can see that. So I would ask Sylvie perhaps to start us off on this question. But I also asked the other panelists if they would also want, to respond to this. And you can do so by raising your hand. Now that you're on video, you can do that. Okay, so perhaps, Sylvie, if I could ask you to take a shot at answering this question, that'd be most appreciated. Thank you.
Yeah, thanks a lot for this question. I think indeed, as every tool brings a lot of opportunities, but I think this issue of privacy is real challenge because obviously, I mean, for instance, we see this with testing of COVID-19. People have to so some people agree to have the test, but they don't want the results to be necessarily shared to everybody and their neighborhood and so on. So obviously, those information we need to maintain enough privacy so that people don't feel exposed and unnecessarily pinpoint them, but at the same time allow for public health interventions. And so we need to find the right balance between those two necessity, between the individual and the society. And so we need to use those applications and other software with this right balance in mind. And so one thing so there are many things that are done to anonymize first the data. If it's not necessary to have a name of the person, but also to only use those individual data for defining areas of risk, but not trying to go to too much granularity so that people are not necessarily identified or identifiable. And similarly, when we do those dashboards where you can also put the cases geographically, we try also not to certain links between database can allow us to triangulate information, and then especially in areas with low population density, when you have few cases, you can deduce who is the case and so on. So when we are in this kind of situation, we really try to delink certain database so that it's not possible to identify people. So there are ways to make sure that the privacy and individuals are protected. And this is the challenge currently. I think this is why it's so important with this new technology, not to assume that the technology in itself is good. The technology is just neutral, and you need to put in place systems and mechanisms to make sure you maximize the positive effect of the technology for the health of the people, and you minimize the negative effect, because there will always be some negative effects, but this is why we need to regulate those new technologies so that the negative effects are less important. And if you for instance, an example I can give, which is something that we are very worried of, is the capacity to re-engineer viruses. And so somehow this technology can be extremely useful, because it enables us to do a lot of research and to better understand also how viruses are functioning, and we can develop treatments and vaccine against those viruses. But the real risk is to have a laboratory accident or a deliberate re-engineering of dangerous viruses. And so that's why we really need to have a regulation of those technologies, so that really the good use is maximized for the health of the people. Thank you.
Thank you very much, Sylvie. I'm wondering if the panelists, the other panelists would like to come in on this, because I think this is a question about, technology being neutral, but what do we need to do to make sure that the uses of technology is translated into positive outcomes? Would any of the panelists want to take on this question? Yes, David, please.
Thanks very much. I agree with the points that the panelists have made, absolutely, and what Sylvie's just said. But I think at the heart of this issue around acceptability, it's the individual, it's the importance of the people concerned. And so in a project that we did at Chatham House a couple of years ago, one of the overriding features was that the provision of information, all of these privacy issues, in a sense, they become more manageable if the benefit to the individual is communicated very clearly, or the benefit to the community at a local level. And I think this vexed issue of having trust and confidence in the decision makers, that really goes to the heart of the problem. And I'll leave it at that. It's a very difficult situation to tackle, but I firmly believe that the people and the trust and the confidence are at the center of this issue. Thank you.
Yes, Dr. Naveen, please. You have.
Yeah, Cecilia, I would like to add to what David said. David, I completely agree. But I would also like to take it up a higher level, that before trust comes trustworthiness. So we need leaders who are trustworthy, and then trust will come. And so it's up to us to make sure we're part of the process that puts in the trustworthy people in places of importance.
Thank you very much, Dr. Naveen. That's a good point. I think there is also another question, which is question 3, which is relating more or less to the same issue that we're talking about now. The PMAC Secretariat will put that up on a slide, but essentially it's talking about the different initiatives that are being used to promote data. But how do we encourage, policymakers, ethicists, health providers, all the stakeholders? No, this is the question 2. If I could have question 3 up on the different initiatives, we can come back to this question. Yes, this is the one. Sorry, that was. Can you go back to the other slide? Yes. Question 3. That's it. Right. And I think this goes back to the same issue we were talking about. And do I have any takers from the panelists and David in terms of what can be done, to encourage, greater use of data, and what is the, sort of lessons that we have learned now in terms of data privacy and confidentiality that we can apply, to have a greater convincing. We talked about trust. We talked about, sort of making sure that we have regulation. Are there specific lessons that we can bring to bear, on this question? Sylvie, please.
Yeah, I cannot raise my hand here. I don't know how to do it, but
you've done that.
No, I think it's really a new social phenomenon. We are surrounded by data. We are all producing data, but we are also all using data. And I think it's really urgent to increase the data literacy and teach all generation, not only younger generation, but how to use data, how to analyze data, how to interpret data, because I think it's becoming easier to get access to those data, but the analysis and the insight is sometimes not so easy. So and I've been surprised since the beginning of this pandemic. For instance, there was this concept of flattening the curve, which is a kind of a very technical concept for epidemiologists and so on. But so many people in the street were talking about it. So it proves that people can learn very fast, even very complex issues, provided we have a good approach to this data literacy. And I think it's very important also to develop, at the same time as we develop those data platform and those capacities to produce data, develop similarly the capacity to analyze and also socialize the data literacy. So that every citizen in the world is not only a recipient of those data, but or just a producer of the data, but really can use those data to improve its own health and make informed decisions about health.
Thank you. I think we also have a question on climate change, and this is perhaps the question for Tegan. I'm asking the PMAC Secretariat to put this up, but I can read the question for Tegan. How much of the global financing mechanisms to combat climate change is focused on addressing the health impact of climate change? And how should we go about promoting greater attention as well as resource allocation on this issue from decision makers and funders? I hope that we will be able to get that question up on a slide, but Tegan, if you'd like me to repeat, or are you good?
I'm good. I have already read it on the Q&A.
Great.
That is a really good question. I'm not sure how familiar this audience is with the funding mechanisms for climate change issues, but there are a series of climate funds, many of which are run by international organizations, including the World Bank, for example. But the Green Climate Fund, or the GCF, is one of the most important funds these days to help support countries in their actions to address climate change risks and to combat the causes of climate change. The GCF reportedly has only spent about 2% of all of its funding in the health sector. However, a lot of that is because they are not getting requests to spend money in the health sector, and they have been trying to increase interest in order to get more applications for that sector. And so in a sense, it behooves all of us in our own individual countries to work to raise the profile of climate change and health risks, which are quite considerable, but for which, if we prepare in advance, there is a lot that we can do to mitigate those risks. In contrast to other areas like the agricultural sector, where you actually run into thermal limits for crop growth, and it's hard to get around those thermal limits. The health sector isn't like that. And in public health, there is an amazing amount that can be done to actually reduce some of the impacts of climate change on public health through advanced planning. However, we all need to advocate that our governments take those risks seriously and encourage countries that can to apply for international funds to get support to implement the kinds of changes necessary to make that happen. I hope that answers the question.
Wonderful, thank you. Now, I think I will probably have a question for both Dr. Nantasid and Dr. Naveen. The question is, what sorts of predictive technologies do you recommend? And I think this speaks to your remarks, Dr. Naveen, earlier. And I will ask the PMEC Secretariat to put this question up. But I think the question is also, aside from which technologies, how do you think it serves us with vaccine efficiency predictions? I'd like to ask Dr. Naveen to answer this question, and perhaps Dr. Nantasid as well.
Thank you. Thank you again for the opportunity. So I was thinking of predictive analytic tools more in the public health domain, not the clinical domain. And so predictive analytics for vaccine efficacy would come under the clinical domain, and that is very much controlled by randomized clinical trials that have a control. And that, so for example, we know the 2 new vaccines come out have upwards of 95% efficacy, and that is through clinical tools. And that's not what I was talking about. I was talking about predictive analytic tools in the public health domain, which is not used. Let me give you an example. 45 years ago, my professor of obstetrics and gynecology, I remember very clearly telling me that there is no way to predict which pregnancy is high risk. So if you have 100 pregnant women, you have to treat them all as if they're high risk, because there's no way to predict which of those 100 will have normal deliveries and which of those 100 will have complicated deliveries. That made sense 45 years ago, and we did that, and it worked because we treated every woman as a high risk. But I'm asking myself today, when the weather forecast can tell me exactly whether it's going to rain on my head within 1 hour, wherever I'm standing in the world, is it really true that we cannot predict which pregnancy is high risk if we can get multiple data sets and multiple data points and correlate them and triangulate them? There must be a way to predict vulnerable populations. So I was thinking of getting into predictive analytic tools in public health domain where we normally have it, even though weather forecasting, banking, music, all that has been disrupted through data. Public health is still stuck in that thing is we don't know and we cannot predict. And I'm questioning that.
Good question, Dr. Naveen. Dr. Nantasid, would you like to also have a go at the question in terms of predictive technologies, but also in relation to vaccines?
Yeah, okay. So is that related to the predictive technology? Is it the question? So the vaccine efficiency prediction. So I think I can address on the vaccine efficiency, which I think should be the vaccine efficacy or something like that, rather than the efficiency. So I think, yeah, so to address this question, I think the efficacy of the vaccine. So I haven't looked through what the outcome they are measured at the moment from the news, but we have like to see what the definition of that, what's the outcome they're looking for the efficacy prediction that they have on the current data, and to see further whether it's like to reduce the susceptibility or to reduce the transmission, or they have some more benefit to reduce the severity. So I think maybe we need to see a little bit more on the phase 3 clinical trial to see what the other outcome that vaccine could provide.
Great, thank you. I think we're very close to the end of the Q&A session, because I think we might want to leave time for the sum up. But I want to ask very quickly if the panelists have any final last words that you want to make in 30 seconds, please. Okay, if not, then I think this was actually, first of all, many thanks to all of the speakers, because this was wonderful. And I think, a vast range of issues that we touched on, but also I think, many lessons that we have learned in terms of the use of technology and how we relate to them in terms of making sure that the human factor is integrated. I don't think I can do justice to be able to summarize, the breadth of the discussions that we've had so far. But I think what I heard was that, technology has a great role in terms of our ability to predict, to address, and to respond to, future pandemics, future threats. But I think we also realize that technology can be neutral, and it really is up to us as the humans to be able to look at, the systems and processes that we need to put in place to make sure that technology and the advances in science work for us, that we all have equitable access, and that we are also able to address issues related to, the ethics of, the use of technology. We talked about privacy and confidentiality. So these are also, systems and structures that we might need to put in place. I think Sylvie mentioned regulation. That's also clear that we need to be able to think of the different types of regulation that will allow us to do that. But I would like to turn to Dr. Colin Quinn, who will have the unenviable task of summarizing this discussion. Dr. Colin, as the slide says, is the team lead for the climate change team in the Africa Bureau for USAID. So Colin, over to you.
Yeah, I'll just spend 2 minutes summarizing the session, and then we kind of introduce us to the next session. But first, thanks to the organizers of PMAC. Similar to Tegan, maybe this is my first foray into PMAC. I come from a climate science background, and the organizers have done an impressive job. Also, thanks to the organizers of this session, so my colleagues from HITAP and Chatham House. And thanks to you, Dr. Cecilia, and to most importantly, to our panelists, Dr. Sylvie, Dr. Nantaset, Dr. Tegan, and Dr. Naveen. I think 2 points rose to the top for me during this session. The first is we have better technology to respond to pandemics now than we have in the past. We heard from Dr. Sylvie talk about combining different types of data sets. We heard Dr. Nantaset talk about how the early health technology assessment can lead to a better vaccine. And we heard Dr. Blaine talk about how models incorporating both epidemiological data and climate and weather data can help predict future epidemics, particularly around infectious diseases. And Dr. Naveen talked about artificial intelligence and big data and predictive modeling. But more importantly for me, what I heard from every single panelist and also came through in the questions was the human component of all of this. And I would extend it farther than a human component. And as us working in this sector, it's all of our responsibility to consider this human component in our work. I thought Dr. Naveen's message about that access to data may provide very large gaps in the future of health for different communities was very powerful. And we need to focus on providing equitable access to data. Dr. Blaine mentioned that data is only useful if it's trusted by the public, and how to focus on behavior change and focus on that human component. Dr. Natasit talked about the early health technology assessment, but farther than that, how it's aimed at informing policy, not just as a set of technologies. And I think Dr. Sylvie did a great job of introducing us to why the human component it should be involved in all 4 aspects of human health decision making. So those were my two main takeaways. I really appreciate all the panelists. I would like to encourage everybody to take the evaluation, and I believe we're going to put up introduce the next session on the screen soon. So thank you all for participating, and thanks again, Cecilia, for moderating.